Good morning, everyone. I am Dr. Amarasekara. I graduated from St. Petersburg, Pavlov State Medical University, and later I obtained my master's from Maharashtra University of Health Sciences, India. Today, this is my first lecture of our lecture series on the topic of basic orthopedics for nursing students. So we are trying to cover all the basics which you know as a nursing student which are related to orthopedics. So today first topic I have decided to teach you regarding the dislocations. To discuss uh, regarding dislocation, we should know the definition of dislocation. Oh, what do you think? What is a dislocation? Dislocation means it is complete and persistent displacement of a joint in which at least some part of supporting joint capsule and some of its ligaments are disrupted. It should be complete and persistent displacement, and there might be some disruption of joint capsule or ligaments. That means a dislocation. Now we should know what is the difference between dislocation and subluxation. Here there are key terms are complete, persistent, and there might be some disruption to the joint capsule and ligaments. So subluxation means it is not complete, it is incomplete, partial dislocation of a joint. So there are the distal part is out of the joint, but it's not completely. So it's and there might not be any damage to surrounding joint capsule or other ligaments. So subluxation means we should know subluxation is an incomplete or partial dislocation. So once you get a patient, you should appreciate whether it's a dislocation or subluxation. So now coming to types of dislocation. It can be congenital or acquired. Broadly, it categorized into two groups, congenital and acquired. Congenital means shoulder joint or whatever the joint get dislocated due to the congenital reasons. Means congenital reasons which predispose to laxity of the joint. So due to joint laxity, hyperlaxity of the joint get dislocated. It's a congenital, it's a genetical. Then coming to acquired. Most common type is traumatic due to any sort of trauma. It can be RTA, sports injury, or domestic injury. Joint get dislocated due to trauma. Then we goes to pathological dislocations. Pathological dislocation occurs when your joint capsule joint disrupted due to some other pathology. As example, if you get a tuberculosis or septic arthritis, due to these conditions, your joint capsule get disrupted, damaged. So due to this damage, joint can be dislocated. Another thing is paralytic. If you have any form of paralysis, maybe polio, cerebral palsy, or CVA, which leads to laxity of muscles surrounding tissues, so joint get dislocated. Then finally, due to inflammatory condition as rheumatoid arthritis, which disrupt the joint capsule, so joint get dislocated. Now you can see there are two types, congenital and acquired. And acquired, it can be traumatic, it can be pathological, it can be paralytic or inflammatory. Now we have to discuss symptoms of dislocations. A patient will come to you with a history of injury and he will complain pain in particular joint. He will complain swelling in that particular joint and surrounding area. And his main complaint will be inability to move his joint. There might or might not be numbness or paresthesia distal to the joint. So patient will come with these symptoms. Patient will give you history that there was a trauma, then he get the pain and swelling, and now he can't move the joint. And he will tell sometimes he get some paresthesia, numbness, inability to move the distal joints. So now you have to appreciate each of these symptoms, and now you have to see the signs. So once you look at the patient, you got the history. Now you look at the patient, you clearly see that joint is out of place. It's discontoured, misshapen joint, and joint mobility is limited. Once you ask patient to move the joint, either he can't completely move the joint or some limited movement is there. You can see the swelling around the joint or bruises, and if you ask patient to move or weight bear on that particular joint, patient will experience severe pain, and there might be decreased sensation distal to the joint, and you have to assess the vasculature. You have to see the distal pulse, you have to see the pulse pressure, pulse volume, and you have to compare with the normal side. You have to appreciate whether any coldness in the extremities, and you have to document all those findings. So you will see the discontoured joint. You will appreciate the limited movement and some swelling and intense pain when you ask patient to move, and there might be some distal neurovascular deficit. So then these are the typical deformities in dislocation. Each joint held in a typical position. So once you see the, you can think there's a, yes, there's a dislocation. Shoulder usually they held in abducted position. Elbow in a flexion deformity. In hip, anterior hip dislocation, flexion, abduction, and internal rotation. And in posterior dislocation, same thing again, flexion but adduction and internal rotation deformity. And if you have a knee dislocation, it's a flexion deformity, and ankle is a varus deformity. So once you see, you can identify that there is a dislocation. That's why patient is holding this particular joint in particular position. Now, thing is, once you get a joint dislocation, now you have to give it a name. So first thing you give is the name of the joint, either shoulder, elbow, knee, whatever it is. So first thing you name it from the joint. Now you have to see whether this is anterior or posterior position of displacement, direction of displacement. How do you name it? You have to name the dislocation by the position of the distal fragment with relation to proximal fragment. If you say anterior dislocation, that means distal fragment displaced anteriorly. Right. Now you have given two names. Now you have to add whether this is, if there is any periarticular fracture, you have to add this fracture dislocation of shoulder joint, right? Fracture dislocation of elbow joint, like that. And next, finally, you have to add whether it is open or closed. If there is any wound communicating joint capsule, now you have to name it as a open fracture dislocation, or otherwise closed fracture dislocation. Either just closed dislocation anteriorly or posteriorly. So these naming should be done. Then you can easily communicate with the receiving end. If you are working in the emergency department as nurse, you get the patient, you give a call to your ED doctor and tell this. Then he get an idea what is I am going to deal with. So now you have seen the symptoms and signs. Now you have to confirm your diagnosis. How do you confirm? you have to take radiographs. You have to take at least two radiographs in two planes at 90 degrees to each other. And these radiographs should be good quality radiographs. And usually once you order, you should order first standard views. Additional views only requires in specific cases. So that you initially order standard views, then decide whether if you can't appreciate anything, then you have to decide on further imaging. And these x-rays should be well focused. Entire joint should be seen. So once you order x-ray, when you hand over the patient with the request form to radiology department, you have to mention that I want to see this joint clearly. So right now you have seen the patient, you have done the x-rays, now your diagnosis has made, and now next thing is management. So in the management of dislocations, there are some principles you should keep in mind all the time. First one is reduce the joint as soon as possible. Please try to minimize the time from the time of incidence and your manipulation. And other thing is most of the first time acute dislocations can be relocate closely. Very seldomly only you requires open reduction. And always reduction should be under adequate analgesia. Either general anesthesia, either sedation or regional block or whatever it is. Patient should be comfortable, adequate, and it should be painful procedure. You should not apply any excessive force, which may eventually leads to post-operative complications, fractures. So this should be very gentle process. Right. Now you have done the relocation. Hmm? After reduction, you have to again do proper examination, confirm the neurovascular state, and you have to get an X-ray and confirm your reduction, and then you have to immobilize the patient according to the joint protocol. If it is shoulder joint, you have to 3 weeks. So we will come into one by one in the time comes. So these are the principles of treatment. So as I mentioned earlier, reduction should be very gentle. So now you have planned it. Now you are going to do it under sedation or a GA. So now you have to insert IV cannula and you have to have all the required monitoring. Then you give your sedation, whatever the sedation you decide, either yourself or your anesthetic colleague will give sedation. Then you apply the traction. This traction, as I mentioned earlier, is gentle traction with counter traction, and you have to manipulate the joint with proper maneuver, not with excessive force. You have to apply gentle traction with the proper maneuver, with proper identification of, with the proper understanding of the anatomy of the joint. Now there are things we have to know. There are some complications of dislocation. It can be acute or chronic. Acute, mainly it's distal neurovascular deficit. Any neurovascular deficit can be due to initial injury or due to iatrogenic due to the method you have resorted for the reduction. Then chronic, first one is unreduced dislocation. That means you tried but dislocation has not been reduced. you have not taken radiograph, then later if you take X-ray, you will see unreduced joint. It's a one point. And other one is recurrent dislocation. Sometimes if there are ligament injuries, labral injuries, something, this joint get dislocated recurrently. So to avoid this, you have to follow proper protocol for immobilization and post-op rehabilitation. Then, with this dislocation, sometimes there might be some osteochondral damages. So, with the time, these patients may develop osteoarthritis. Other known complications of dislocation are avascular necrosis. To avoid this, you should minimize your time delay of manipulation. To avoid this long, this is a very bad condition, so we should avoid these type of things. So you have to minimize your gap between incidence and your manipulation. And other complications such as myositis ossificans and joint stiffness. Joint stiffness again, as I mentioned earlier, after reduction we have to immobilize, but this immobilization should not be more than required, because if you immobilize for further time there might be joint stiffness. So as per protocol you have to immobilize, then remove immobilization on particular after particular time period, then you start the guided physiotherapy. That's how you can minimize the post dislocation joint stiffness. Right. This is, I think I mentioned earlier, you should not apply excessive force during the reduction. It should be very gentle form of reduction. Forceful manipulation will lead to damage to capsule as well as fractures. So once you try twice, it not reducible, then you have to rethink, revisit, and think. There might be some reason why you are failing with the close reduction. Maybe some soft tissues, some bony fragment are interposition between the joint. There may be some damaged joint capsule. So if it is not reducing with close methods, you have to revisit, rethink, go back to your X-ray and see is my diagnosis is correct, whether correct my position maneuver is correct. So these things you have to keep in your mind. No no point of trying to relocate repeatedly with excessive force. So when there is doubt, you have to call your seniors. Now we are going to each joint, discuss each joint. Shoulder is the most commonly dislocated large joint, followed by elbow, then hip, metacarpophalangeal joint, facet joints of cervical spine, and AC joint, acromioclavicular joint. So most commonest dislocated large joint is shoulder joint. So we discuss shoulder joint dislocation. So to understand the shoulder joint dislocation, we should remind our anatomy, shoulder joint anatomy. At least we should know about the bony anatomy. Here you can see radial head is attached with the glenoid labrum in glenoid rim, and acromion process you can appreciate here. Clavicle is there, and this shoulder joint covered with the rotator cuff muscles. There are four rotator cuff muscles which support in the shoulder joints: supraspinatus, infraspinatus, teres minor, and subscapularis. So now you can see in this picture how this glenoid rim and glenoid labrum is your shoulder uh, head of humerus comes and join with glenoid cavity. You see, it's not deep; it's shallow, and the shoulder joint has very variety of movements. That's why it's get easily dislocated than other joints. So in this X-ray, you should be able to appreciate the bony structures. Here you can see humeral head, acromion process, coracoid process, and clavicle, and the glenoid tree. So you should be able to read these radiographs. So now we are coming to types of shoulder joint dislocations. Most common type is anterior shoulder joint dislocation. It is subcoracoid. Why it is called subcoracoid? Now we know, always we describe the relationship of distal part with the proximal part. Now humeral head has dislocated anteriorly and it has gone subcoracoid. We need the coracoid. It is the most common type. 60% of the shoulder joint dislocation are subcoracoid. Then we are going to anterior inferior dislocation. Now it has dislocated anteriorly and it has gone inferior, and now it is located in just below the glenoid. 30% of them are subglenoid. Then rare one, this is posterior dislocation. This is occurs most of the time when people fall on ground without consciousness, such as with the epileptic fits, electrocutions, and other rare thing is true inferior dislocation. What we were discussing here, now the first type, anterior dislocation, what do you call it? Subcoracoid dislocation. So here now you can see humeral head has come anteriorly and it is placed beneath the coracoid process, and now you can see posteriorly part of glenoid rim and labrum is visible. Now, you know these things you have to identify in the X-rays. Now you see humeral head has dislocated from the glenoid rim and it has come forward, and it is just beneath the coracoid process. This is called anterior dislocation, subcoracoid type. So now we'll see the X-ray film, how it's looked like. See, here I have marked these things: coracoid process, glenoid rim, and labrum and humeral head. Here you can see posteriorly glenoid rim and labrum is visible. Humeral head has come forward. This is an anterior dislocation, subcoracoid type. Then next one is in antero-inferior. I have subglenoid. Now what has happened? Shoulder joint has got dislocated. Humeral head has dislocated anteriorly and it has gone inferior. Anterior, inferior. It has gone inferior. Now you can see the whole sort of whole the glenoid and labrum. It has come subglenoidally. In this picture, you can see coracoid process and the glenoid labrum. So same thing in a X-ray. Here, please see these. You can see glenoid rim clearly. You can see because this has completely come inferiorly, and humeral head has gone subglenoid, and here there is a fracture also. This is a fracture dislocation. You can appreciate greater tuberosity fracture. The next type is posterior dislocations. It is rare. It occurs on with electrocution, epileptic fits. Here humeral head goes posteriorly. You can appreciate, you can see the glenoid rim anteriorly because head has gone backward. This is called posterior dislocation. I also already told these things. It occurs in electrocution and epileptic fits. In this X-ray, not like in anterior dislocation, posterior dislocation sometimes difficult to figure it out in X-rays. You see here, in the first film, you should be able to appreciate the glenoid labrum, glenoid rim. It is clearly visible, and humeral head has gone backward. And specific this type, I have marked in second middle X-ray. This is called light bulb appearance. This is pathognomic for the posterior dislocation. And as I mentioned earlier, sometimes it's difficult to figure it out. Posterior shoulder joint dislocation with AP and lateral access. So in this case, you have to ask for scapula Y view. In the last picture, it's a scapula Y view. Here you can see the posterior dislocation. So once, if you can't identify dislocation in standard views and still you have doubt of dislocation, then you have to order specific views such as axillary view and scapula Y view. This is the true inferior glenohumeral dislocation. So other thing is reduction techniques. So there are several reduction techniques. You have to familiar at least 2 or 3 methods because by only method you will not be able to relocate each and every dislocation. So if your one method is failed, you should know another method. So there are few methods. This how they reduce. This is Cocker's manual. So these at least 2 or 3 methods you should be familiar. Then now you have reduced the joint. Then what you have to do? You have to fasten the joint into body, strapped it, and it should kept for 3 weeks. So you have to appreciate the if there are any neurovascular deficit, and then you have to confirm your relocation by a radiograph and keep immobilized for 3 weeks. Then after 3 weeks, you have to start gradual physiotherapy. But during this time, you have to avoid movements such as abduction and external rotation more than 90 degrees, at least for first 6 weeks. And you have to rehabilitate the patient with guidance of a physiotherapist. Next dislocation, hip dislocation. There are 3 types of hip dislocation. Commonest type is posterior dislocation, then center dislocation, and anterior dislocation. Center dislocation is also like anterior dislocation. So in posterior dislocation, what will happen? Femoral head get dislocated and it push backward posteriorly from vestibular. And in anterior dislocation, it's come forward from the acetibular. So for to get a hip dislocation, there should be massive force. Most of the time, these thing happens. Drivers, while they are trying to pedal the brake when see the vehicle is going to make accident, they try to pedal the brake and the force coming from the axial direction. As I mentioned earlier, posterior dislocations are the more common. So almost 90% of hip dislocations are posterior. As I told, this axial load in flex abducted hip. This is happening while pedaling the brake. The position, as earlier we mentioned, is flexion, abduction, and internal rotation. And anterior load is applied to the hip when leg is abducted. Is abducted and externally rotated hip get the force, then only you get the anterior dislocation. And position is same like above, flexion. Now it's come to not adduction, this is abduction. In the posterior dislocation is adduction, this is abduction and external rotation. So you can see in this picture, this is pathognomic picture of a hip dislocation. Patient leg is held in the typical position. Those that affected limb closely restricted movements, flexion, adducted and internally rotated limb. Flexion, adducted and internally rotated limb. This is how typically look like a hip dislocation. Hip dislocation reduction, it's almost always should be done under general anesthesia. Patient kept in supine position. You need assistant to hold pelvis. Then you have to apply longitudinal traction and do the maneuver. In this X-ray, you can see hip dislocation right side. Femoral head has come forward from the vestibulum. See here also dislocation. These X-rays you have to see. And once you have done hip reduction in hip dislocation, you have to apply skin traction for 3 weeks. After 3 weeks, you can remove the traction and start physiotherapy. But patient should be non-weight bearing for another 3 weeks. Then up to 6 weeks, patient should be non-weight bearing and he should follow supervised rehabilitation physiotherapy. And next dislocation we have to discuss is elbow dislocation. This is the second most commonest large joint dislocation. This elbow dislocation can be simple or complex. A complex dislocation means there might be radial head fracture or coronoid fracture or and associated ligament injuries. If you get elbow joint dislocation with radial head fracture, coronoid head fracture, it's named as cerebral triad. It is an orthopedic emergency. So, simple elbow joint dislocation, it is close reduction. But in cerebral triad, you have to think of open reduction and internal fixation and the reconstruction of lateral collateral and medial collateral ligament. So if you get a cerebral triad, yes, initially you have to do the close reduction, then you have to get X-ray, CT scans and see the position of radial head coronoid process and decide your definitive treatment. Yes, mode of elbow joint dislocation we discussed. It's a fallen outstretched hand and immobilization for 3 weeks, then start physiotherapy. And this is very notorious joint. If you immobilize more than 3 weeks, it's tend to get restrictions, joint restriction, and very difficult to come out of. So you should start early mobilization. Only up to 3 weeks, 2 to 3 weeks, you should be immobilized after simple elbow joint dislocation. This is an X-ray of posterior dislocation. You can appreciate this is your humerus and radial head and your coronoid process. Cochlear groove joint has been dislocated. The other dislocation is a small joint, that is interphalangeal joint dislocations. These things occurs with the sport, most of the time sports injuries, where people who play with balls like basketball, volleyball, beach volleyball, handball, this can be reduced in outpatient department. This is not not complicated. It is a simple procedure. You have to have the counter pressure to the proximal phalanx, and you have to give traction, axial traction to the gentle axial traction to the distal portion, while giving some pressure to the distal fragment. So after this reduction, you can apply body strapping, and you get an X-ray, and confirm you have relocated. And after 2 or 3 weeks, you can start early mobilization. Yes, now we are coming to an end of our first lecture of the lecture series of basic orthopedic for nursing students. If you like the video, please uh, click the like button and subscribe our channel, so then you will get notifications. And finally, please remember these things. These are key points in dislocations. Close reduction is sufficient in the most of the time. Close reduction is the mainstay of the treatment of dislocation. Very rarely only you need to do open reduction. It is only for specific conditions. And usually you see when you get a fracture, you splint, patient gets pain relief. But in dislocation, even you put any splint, patient pain won't be subside. And main point is reduction techniques should be very gentle, very gentle. You should not apply excessive forces. You should not apply excessive forces. You should not apply. It should be very gentle, and patient should very comfortable, give adequate analgesia, and do the proper maneuver. Whenever you are in trouble, whenever you can't, you are unable to relocate the joint, then always call for help from seniors. And if you are tried 1 or 2 times, still not you are unable to relocate, then you think what can be the reasons. It can be some interposition of soft tissue or bony fragments. So then you again revisit the X-ray and try to approach, try to see what is the reason, and then you plan your further management accordingly. Because excessive force is not an answer for a difficult case. You should not apply excessive force. Okay, thank you very much. And again, I tell you, please subscribe the channel and like the channel. Thank you.